Good morning, Borodar, and welcome, Croiser, to our webinar on shared lives and mental health crisis, which we hope will be informative, engaging and inspiring. We have lots of speakers to give you multiple perspectives on the work, and there will be a chance to ask questions at the end. So please use the chat function or the Q&A function. You'll see those buttons at the bottom of your screen to post your questions, and we'll pick those up at the end. My name is Benna Waits. I'm Joint Head of Psychology, Counselling and Arts Therapies for an Iron Bevan University Health Board, and I'll be chairing and presenting this morning. Emma is our Crisis Project Manager on the scheme, and we work really closely with her. So over to you, Emma.
Thank you. Morning all. So I'm Emma Jenkins, and I've worked with the South East Wales Shared Life Scheme since the conception of the collaboration back in 2012. And I was very proud to be appointed as the manager for the Mental Health Crisis Project in 2019. And it's been my absolute privilege really to work so closely with the home treatment teams in developing what has now become an established service for mental health across an Iron Bevan. And very proud to be recognised by the World Health Organization for our efforts in getting this service up and running. It's absolutely remarkable. I know Alex has given you an overview of shared lives, but I think this quote really sums up the ethos for me. It's to provide an ordinary family life where everybody gets to contribute, have meaningful relationships, and are able to be active, valued citizens. And that is our goal within Shared Lives, to achieve those. So a bit more about the South East Wales scheme itself. So we are a partnership across Blaen y Gwent, Caerphilly, Merthyr Tydfil, Monmouthshire, Newport and Torfaen. We are the largest scheme in Wales, and it says that we provide over 400 arrangements in over 200 households across Gwent. And we provide arrangements for any adult, so anybody over the age of 18 with an identified support need. And that can include a variety of support needs: learning disability, dementia, physical disability, and mental health in this particular instance. We are a large team, as you can imagine, to be able to effectively manage all of those arrangements, and we're very happy to continue growing. As I said, our admin team are the absolute crux, as anybody will appreciate. Without an efficient admin team, a service can't function. So I'd just like to thank them for all their continued support. So Shared Lives basically is whereby a carer and an individual who need care or support share their home, family and community life. And it's really that human element that for me makes Shared Lives just so different to other services out there. Within South East Wales Shared Lives, we've expanded quite greatly actually. So individuals accessing our service can receive a variety of support. So that can include daytime sessional support, short respite stays, transitional periods, periods of assessment following hospital discharge, emergency support, or they can live long-term permanently with carers. Our carers are remarkable. They are recruited from local communities, just you or I. They provide arrangements from and in their own homes. No formal qualifications are necessary for our carers. That's not the point. It's their life experience and their willingness to learn and share and just care, really, that makes them who they are. They will undergo a thorough assessment with us. It takes roughly around 3 months. The usual checks, DBS, references. They undergo a health and social care induction. And at the end of the assessment period, they are taken to an independent panel where hopefully everybody is satisfied, and then they're approved to commence working with us. They receive ongoing training and support and supervision then from our scheme. And we really do encourage training, ongoing professional and personal development for all of our carers. As Alex mentioned earlier, the scheme is regulated. We're registered and inspected by Care Inspectorate Wales. And they obviously are in touch regularly in order to make sure that we are fulfilling all of our roles in line with regulations, that we're assessing carers, monitoring arrangements effectively, and meeting all of the required standards. Just to give a flavour really of the numbers involved, here are the figures from last year. And to me, knowing how Shared Lives has developed over the years, back in 2012, the long-term percentages there would have been perhaps even way over 2/3 of the chart. But for me, this is a clear indication that our collaboration really has developed into more of a preventative model, whereby the sessional and respite services are now being utilised to enable individuals to live with their main carers, be that their family, within their own homes for a longer period, really. And we utilise the session and the respite to just give that community involvement and the main carers a little bit of a break. And for me, what is remarkable in these COVID times is that the emergency for referral rate really shot up last year. And I think that's a reflection of COVID, as many of the referrals were as a result of carer illness or family breakdown. And we were able then, our carers were wonderful and able to respond even in a pandemic. So as a collaborative scheme, we sort of recognised that there was scope to develop and widen really the use of Shared Lives. And hence in 2016, we gained Welsh Government funding to launch a health initiative project. And the objective of that project was to specifically look at, and this is from a social care context, was to look at referrals that prevented hospital admission, be that physical or mental health needs, support timely discharge, offer periods of assessment, and really focus on working with individuals with dementia, mental ill health, and end-of-life care. That scheme is still up and running, that project within the scheme. We've received nearly 500 referrals, 2/3 of which have progressed to successful arrangements. We've had to recruit new carers to specifically work with those referrals. And as you can see with the figures, a large majority of those referrals are working with individuals with a mental health diagnosis. But this is from a social care context. But what did happen then is that health initiative project then set the groundwork and was the blueprint really for this project's development. And in April 2019, we signed a service level agreement with the Llves Health Board to specifically provide Shared Lives arrangements for those people experiencing a mental health crisis. The project has run for 2 years now, and due to its success, we've recently been extended with recurrent funding and expanded to cover the whole of Gwent. So as Benna mentioned, we provide arrangements. It can be up to 4 weeks, but typically it's averaging sort of 2 weeks for people who've had an inpatient stay and are recovering, or as an alternative to inpatient admission initially. In this context, Shared Lives is an opportunity for people to have a different experience in crisis. And I think when we speak to Nikita shortly, she will testament to how that can differ from a hospital environment. It offers more choice to both individuals and the staff. And this service is fully supported at senior levels within the health board and the local authorities. So how does it work? Myself and my colleague, we as the Shared Lives team within mental health crisis, we work really closely with the crisis home treatment teams. As Benna mentioned, those relationships are absolutely critical in getting this service to run effectively. So we base ourselves physically within the home treatment teams throughout the week. We sit in, attend ward rounds, make relationships with the consultants. The ward staff are aware of us. So we've really developed that rapport, that trust, and we've built that over time. So the crisis home treatment teams would identify a patient that's suitable for shared lives, and they refer that person to us. It would be then my role then to go meet with that person on the ward, to have a chat with them, answer any questions or queries, offer reassurance. I often use the YouTube video of Nikita, actually, if they have any concerns. I'll explain and say, you know, we have a patient who's previously used the service. Would you like to hear their thoughts and feelings? So that's a really good educational tool. And should that person then wish to go forward with the service, I will gather much more information about them, the personal information, what matters to them, to enable me then to commence the matching process to identify a compatible carer and household. And within that matching process, as Alex briefly mentioned earlier, I'd look at the person's hobbies, their interests, any cultural preferences, the location of the carer's home. Would they prefer rural or urban? Are they looking for a quiet environment? The household dynamic, you know, are they children, their pets? You know, pets are so important. And the makeup of the carers, if they're male, female, a couple, single, do they work, are they retired? And so we can really get a good feel for what is going to be the suitable environment. And once we've identified that carer, our household, we arrange for introductions to take place. And this can either take place at the ward or at the carer's home, whichever the individual feels more comfortable with. And it would be then a Shared Lives role then to facilitate that introduction. And if both parties agree, then the arrangement can actually start immediately. So potentially, timescales wise, the arrangement could happen the same day as the referral. And that was happening much more frequently before COVID. As you can appreciate, there's requirement for a negative COVID test from discharge from the ward at the moment. So that can add, you know, a further few hours whilst we're waiting for that to be processed. But many of our arrangements can start the same or the following day. So it's really reassuring for somebody, because the patients explain to us, the last thing they want really is to build the anxieties build about going somewhere new, and then all of a sudden then they're waiting for 2 or 3 days. That's not helpful either. So we like to really go with it. And although we work really closely with the home treatment teams and hand in hand, and we have a wonderful rapport with them, we have really defined roles, and it's very important. Really, our operational processes really highlight the specific roles each of us undertake. And the crisis team role really is to support the individual, whilst the Shared Lives team support the carer. So the crisis team would, as it says there, they'd risk assess the individual, they'd share all the pertinent information with Shared Lives prior to the referral. They'd regularly visit, they'd support goal planning with the individual. They're responsible for discharge planning, and then for connecting up any sort of multidisciplinary input required. Whilst Shared Lives, we match, we identify the carer. We then develop a personal plan with the individual, which really identifies the support needs of the person, but also the outcomes, the goals, what's important for them, and how they would like the carers to support them in achieving those. And we monitor that then throughout the whole arrangement. We have regular visits, and some of those visits are coordinated in line with the home treatment teams, and we undertake joint. And we also offer a 24-hour on-call support service to our carers via our on-call management team. And that's actually really critical for the carers to know that in the middle of the night, if something happens, if there's a query of something, then they also, obviously they have access to the wards and to the clinical staff, but they also have access to us on call for that support as well. And as well as then the ongoing monitoring and development of our carers. In this particular instance with the Mental Health Crisis Project, we gather the evaluation data for both the individual and the carer throughout the arrangement. As Benna mentioned earlier, individuals will identify goals that are important to them and how they would like these to be met throughout the Shared Lives arrangement. And we then monitor and review this at the end of the arrangement. Now, many of the goals that have been identified over the last 2 years have similar themes, and they range from increasing confidence, gaining more independent living skills, domestic house tasks, budgeting is a big one, as well as sort of medication management. And these are, when you look at these goals, they can appear to be quite simple, and many people may take them for granted, but a little bit of support and encouragement and developing confidence in these areas can really have a massive impact on somebody's life and supporting their recovery. And so it's really rewarding when we review these at the end of an arrangement and we mark the scores. And if an individual feels that they've achieved or partially achieved meeting that goal, it really is rewarding, and that's then fed back to the carer, obviously, as they offer that level of support. And the analysis for the evaluation then is fed back then to the health board, and the data is extracted, and that's some of the figures then that Ben has shared with you earlier.